Hello, everyone. Good afternoon. My name is Rosli. I'm from Malaysia, and we are in the Meet the Expert session, and I will be co-hosting this session with Dr. Yeo from Singapore. The actual experts are really the panelists. So let me introduce you the three panelists that we have. Dr. Kenneth Sin, the eminent cardiac surgeon from Singapore, Professor Sok Chour from Cambodia, the previous president, and congratulations, Sok Chour, for having this meeting for the first time with AFCC. And of course, Professor Alex Junia, and he is the incoming president for AFCC. So we have got an eminent group of panelists. The way that we are going to do this session is we're going to break it up into approximately 30 minutes each. We're going to go through with you a case each, and at certain points, we will be asking the panelists about their thoughts on it, and we will then go through the case, and hopefully by the end of the day, you will learn something about the case that is going to be presented and how you would diagnose and then manage this patient. So let me start off first with a young patient with exertional dyspnea. This is a 39-year-old Indonesian sailor. He works in an offshore oil rig. He's been fit, exercises regularly, but for the last 4 to 6 months, he's been experiencing a reduction in his effort tolerance, and he's in functional class 1 and 2A, not 2B, class 1 to 2A breathlessness on exertion. So this is what was done. So that was a very brief history, and we'll carry on as we go along. An ECG that was done showed that he was in sinus rhythm. The abnormality that is seen is left ventricular hypertrophy. So if you calculate the S wave in V1 and the R wave in V6 is 39, and anything more than 35 is considered as LV hypertrophy. So obviously he had an echo done, and his echocardiogram showed that he has LV hypertrophy, a bit asymmetrical. The IVSD was 2.3 centimeters, and the posterior wall was 1.6 centimeters. So remember that he is a fit person, but presenting with LV hypertrophy. Echo shows asymmetrical LV hypertrophy. So the first question to you, perhaps, Alex, is how would you differentiate LV hypertrophy in a person, in a sportsman, from the echo, and you know, this is something which is quite common. A sportsman, a trained heart, also has LV hypertrophy. Would you could you give us some pointers to the differences?
Usually they have good diastolic function. The athlete's heart patient compared to those with abnormal or pathologic left ventricular hypertrophy, and to really see whether they're due to athlete's heart or pathologic. Sometimes they're made to undergo detraining, and then that's when we will see that there is improvement in the LV, in these LV dimensions.
So LV dimensions means to say that in sportsmen, what is it? Is it dilated? Is it normal?
For sportsmen, sometimes it's depends on the type of exercise that they do, whether they're endurance exercisers or the resistance exercisers. So, but they can be some can have dilatation, but the muscular wall, there is the asymmetrical hypertrophy we don't usually see in these patients.
All right. Kenny, you seem like a very fit person. So have you checked your echo, and do you know the differences between a trained heart like yours and LV hypertrophic cardiomyopathy? Can you please unmute yourself, Kenny?
Sorry.
Yep. Yes.
Thanks, Rosli. I'm not a fantastic athlete, so I think my heart will be normal rather than abnormal.
Okay.
So, and I trust that I don't have any hypertrophy.
All right.
Hypertensive or otherwise.
All right. Okay, let's go through, and these are some of the differences that you will see. So you've on the left side are some of the things that you would be able to see. And on the right side is something which is quite important because for an athlete heart, they are rarely very severely LV hypertrophic. So anything more than 15 mm, for example, you have to think that it cannot be a trained heart. So the LV cavity tends to be a bit larger for an athlete heart. And for hypertrophic cardiomyopathy, it tends to be smaller. Both can have LA or left atrial enlargement. Both can have bizarre ECG patterns. That makes it very difficult. But for hypertrophic cardiomyopathy, if you do, Doppler studies, there will be abnormal LV filling, and the thickness. Once you stop exercising, then their thickness will come down with deconditioning in the trained heart. Remember always the family history of hypertrophic cardiomyopathy, of course, pushes it to Hukam. And for trained heart, if you push a patient for peak oxygen capacity or exercise capacity, it will be increased when the person exercises. So these are some of the important differences, and this is sometimes can be quite commonly overlapped, and you don't know which one is which, but these are the factors you look at. Now, this is actually an old guideline, but I think it's still pertinent. Hypertrophic cardiomyopathy is an unexplained LV hypertrophy. There is non-dilated ventricular chambers, and there is an absence of any other causes that may produce the magnitude of LVH. So the LVH maximum wall thickness is more than 15. Well described by Eugene Bonroll and Morrow in 1959 of a functional aortic stenosis. So this has been well described before. Really, the cause for hypertrophic cardiomyopathy is there is a bizarre hypertrophic myocytes with abnormal alignment in the loose connective tissue. So you have loss of normal syncytium and also electrical connections. Do remember, not all patients with Hukam has got asymmetrical septal hypertrophy. 10% can have symmetrical LV hypertrophy. And also, on the other hand, 10% of hypertensive cardiomyopathy can have asymmetrical LV hypertrophy. So do remember this. It's not an uncommon thing as we think it is, because it is definitely more common than in other genetic diseases that we know of. So it's not an uncommon problem. So it is really a genetic disease, but you only have about 70% of patients with a family history. So sometimes you may not have a family history. So, and you do know that it's difficult, it's probably hereditary, but sometimes you may not have hereditary because there is no history because of the fact that you can have a mutation that can occur. But generally it is hereditary genetic disease. Okay. All right, Sok Chour. I know that the history was very brief, but what are the things that you would like to find out from a patient with, in this patient, for example, or for a person with hypertrophic obstructive cardiomyopathy? Can you unmute yourself, Sok Chour?
Can you repeat again?
Yeah. Any other history or any other things that you'd like to know from his history in this patient with Hukam?
Yes, especially the family history of the patient. Yeah, because it's a young patient and in the family, it's very important for me. Yeah.
I think you were spot on, Sok Chour. And really, the most important thing is to find out the history to suggest risk of sudden cardiac death, because they can die suddenly. I remember a senior of mine in UK, London, he was trying to catch a bus. He was known to have Hukam and he had sudden death. So this is very important because you want to improve or reduce improve survival, reduce mortality. Sometimes they have been informed to have a valve disease. So, MR is something which is common. Obviously, in our setup, we should not be ruling out coronary artery disease. In fact, this man underwent a coronary angiogram before being referred to us, and that was normal coronaries. And why is the predictors of sudden cardiac death is important? And because again, you want to reduce mortality and improve survival. The history is very important. So in a young person, exertional recurrent syncope. So look out for it and ask for it. A family of sudden cardiac death. So that's a very strong risk factor. And then when you evaluate diagnostically, if you have an LV hypertrophy of more than 30 mm, so 30 mm and more, then the risk of sudden death is higher. If a person has non-sustained ventricular tachycardia, especially when you have a chance of doing Holter monitoring, and when you put up on a stress test, the stress test doesn't rise appropriately. So these are the important factors for you to consider, because you have then to think whether the person requires an ICD. So he had a stress test done. For a young man of his nature, 9.5 minutes was not very good, but his BP and heart rate responses were appropriate. There was ST depression at peak exercise. So this echo also, his echo also showed that he had moderately severe MR, and you can see that in the left atrium, in this case directed towards the posterior LA wall. What do you think is the cause of MR, Alex, in the person with Hukum? Is there a reason for this?
I'm not really sure, Rosli, but probably there's not the coaptation might be affected, but not really sure about that.
Yeah, I wasn't sure myself until I prepared for this. Sok Chour, any thoughts on it?
Yeah, I think probably this MR due to ischemic heart disease, because some hypertrophy can give the obstacle for the coronary perfusion. So I think probably can due to ischemic problem.
All right, because they have got severe LV hypertrophy sometimes. Kenny, your thoughts? You do this, you know?
Well, I don't know. We hardly ever encounter MR from a hypertrophic cardiomyopathy. I mean, presumably it's functional and
all right.
Yeah.
You have to blame KK for that. He doesn't refer you cases. Okay.
No, he holds them for himself.
Yeah.
All right.
You know,
yes, KK, you can add on.
Yeah, I think for Hukum, I think the images, I wasn't sure, but you know, certainly we should consider systolic anterior motion of the mitral valve. Sometimes it occurs, it doesn't always occur, and it's also a bit dependent on sometimes loading conditions. So in this case, I would look carefully for SAM, you know, and if SAM is present, then it might be a cause of the MR. In this case, I wasn't sure really, but probably good to look at it again.
All right. Yeah, I think that's a very important point. You know, the cause of MR can be a primary valve disease by itself. So obviously, if you have primary valve disease, it has to be repaired surgically. So the option is very clear. But if you have, as what it's mentioned as systolic anterior motion of the anterior mitral valve leaflet, then it is functional and it can actually be corrected. So a lot of people actually say that it might be is due to venturi forces, you know, because of the dynamic changes in the LV hypertrophy, the asymmetrical enlargement of hypertrophy. It is probably not so. The anterior mitral valve leaflet is actually longer than usual, and it does pushes the valve into the outflow tract. And then when it does that, you can actually have a leak. And I'll show you the pictures afterwards. So these are data to show the anterior mitral valve leaflet length as compared to control is much longer, and that causes the SAM. All right. So you have the asymmetrical LV hypertrophy that I showed on the left before, and on the right side is the systolic wall and systolic anterior motion of the anterior mitral valve leaflet, or SAM. So not Samantha, but SAM. So here you have it. This is gated. So this is a mitral valve. So it is opening, and when it closes, you can see that an anterior mitral valve leaflet comes up and touches against the septum. This causes obstruction. But at the same time, that can also cause MR. So once again, if I were to be able to slow it down, so just to show you what SAM is. So as it closes, let me see now, as it closes, then it starts to go up a bit. Yeah. So, there you can see the anterior valve leaflet moves up, and that causes obstruction, and that can also cause the MR. So both the symptoms can be related to the obstruction and also MR. So breathlessness is due to that. So remember this is an interesting point when you do your echo. All right, so please feel free to stop me at any point in time. So once again, another view. I won't go.
Are there recommended maneuvers to show the MR further? No.
I don't really think so. You may do a Valsalva that will increase the obstruction, and that may also increase MR. Any views on that, KK?
I think yeah, changing the loading conditions can help, and sometimes when patients are tachycardic, it also may get worse. But at the time of the imaging, it's sometimes hard to make all this happen. Yeah, but I think the Valsalva maneuvers in general, anything that worsens the MR, would be able to show the the SAM as well.
Okay, so let's move on. This is the peak gradient across the LVOT 150 mmHg. So obviously this is significant. This is a classical the ECG, the echo wave. We call it a scimitar type of wave. And I'll just show you what is difference between subvalvular membrane and also in HOCM. So you can see the difference in terms of the type of Doppler signals that you see in HOCM. So that is very classical. All right. So let me ask then, what is the prevalence of LVOT obstruction if you know? But what is importantly, what is its implication if you have an LVOT obstruction? Sok Chour, would you try to hazard? Would you like to hazard a guess?
I'm not sure.
I don't remember figures myself. Alex?
No figures.
Okay, but its implication. Do you think that?
I think that increases the risk for sudden cardiac death in these patients.
Yeah. Kenny, anything to add on that?
Well, I think the incidence is not really very high, given that we hardly have any referrals for surgical intervention for this. But certainly, I think you need to recognize it because the risks of events are very high in this subcategory.
I think you need to address your complaints to the cardiology department. It's not very uncommon, apparently. Apparently, there have been work done, and 70% of patients actually have an LVOT obstruction. And this is described as peak gradient of more than 30 mmHg. Half even shown at rest, and half when you exert the patient or put the patient on exercise. So if you're not sure, sometimes this is what we do. We tend to put a person on a debutabine stress echo and to see whether it increases with exercise. And you're right, Alex, because it does have an impact, because if you have an obstruction of more than 30 mmHg in HOCM, then the death rate, HOCM-related death, is higher. Patients that go into heart failure and heart failure death is also much higher. And to a small extent, the risk of sudden cardiac death is also higher. So do remember this, because we should not be just pushing aside HOCM. If they have outflow obstruction, you will have to address this. All right. Okay. Anyone who can share with me the goals of treatment? I'm afraid to ask KK because he will ask me afterwards about his kids. So I'm going to keep quiet about this. But feel free to just share with us your thoughts on the goals of treatment.
I think foremost should be the addressing whether this patient has a high risk for ventricular arrhythmias or for sudden cardiac death. So I think related to that will be the family history, any prior history of previous arrest. So yeah, and the severity of the obstruction.
Right. I think it's quite fortunate for him that he doesn't have all those, and you can see that the LV hypertrophy is not very thickened. It's only 2.3. But the goals of treatment is really to alleviate the symptoms, and this can be done with medical therapy. Of course, a reduction in obstruction, especially for patients who do not respond to medical therapy, will help to reduce the obstruction and symptoms. And you would also like to also consider reduction of MR, because MR does add to the symptoms. And as you said, the reduction in sudden cardiac death. But one of the other things that we tend to forget is that we need to remember that this is quite likely a hereditary problem. We should screen all first-degree relatives, including the children. So this is something that we need to remember. So those are the things that I feel are important. Okay, remember always, ladies and gentlemen, the medications to avoid, especially they can actually come with hypertension. So you do remember not to give any medications that can increase the gradient across the LVOT. So things like vasodilator, if you have to give it, you've got to be very careful about doing it. But you should think about not giving it. Positive inotropes or symptomatics that can actually cause the LV obstruction to be worsened. Now, the medications to administer, the ones which are common, is a beta blocker and verapamil. What it does is that it slows down the LV. It has and also negative inotropy. So what it does is it reduces the LVOT gradient, and with this, the symptoms can be reduced. Disopyramide is apparently much better than beta blocker, but we do not have it in Malaysia, so that's going to be difficult. So essentially, people start on beta blocker. If not, then maybe even verapamil. So this patient still had symptoms after optimizing beta blockers. What do you think is the next thing to do?
Actually, Rosli, I was going to ask you, what about mavacamten? I mean, I actually don't know whether it's available in Singapore, but mavacamten, was just was it late last year? They announced it at AHA, if I remember correctly.
Yeah. So we will touch a bit about mavacamten afterwards. So he had symptomatic, he's still symptomatic after a couple of months. So I feel that the treatment options here would have to be much more because he is a young man. He needs to work normally. So there will be two things, which is a septal reduction procedures, either by surgical myomectomy or alcohol septal ablation, and the novel medication that KK touched about, which is mavacamten, the first drug in its class. So this is surgical myomectomy, trying to shave off the basal septum, and you reduce obstruction, and the patient's symptoms would improve. And this is the seminal paper that showed that the survival is actually improved in person who developed or who had surgical myomectomy. Kenny, I'll give it your say. And to be fair to you, anything that you'd like to say about surgical myomectomy, other than saying that it should be the gold standard in terms of treatment?
No, not at all. I think medical therapy is still first line for HOCM, and I think where they fail medical therapy, then one of the things to consider is septal myomectomy. Septal myomectomy itself, is not that straightforward. That you can get residual gradients, and there may be issues in terms of even with the presence of SEM, whether that would adequately cure the systolic anterior motion. So, we may even have to do plication of the anterior leaflet. But I think there are other methods as well, which you haven't quite mentioned. I'm sure KKO also will, I think the use of pacemaker and KK mitral clip as one of the alternative options for SAM in HOCM.
That's interesting. Yeah, I did that. We did that in one case. I did a case where we did reduce the MR and the gradient. The HOCM continued to grow though, so I then went in with ablation. And the only reason why we did mitral clip first was because the patient had a torn cord at the same time. So, that SAM plus a torn cord made things worse. So we did both for that particular patient.
All right, that's interesting. All right, thanks. Okay, so alcohol septal ablation is the other one. So this is Alex Junia when he was in the 80s, when I first met him in Penang 2 or 3 years ago. So he first performed alcohol septal ablation in 1994. But there have been lots of reviews, at least when you compare the latest trials to show the differences between alcohol septal ablation and septal myomectomy. Importantly, the long-term all-cause mortality and short-term all-cause mortality has no difference. The peripheral complication obviously is less with alcohol septal ablation, but re-intervention, pacing dependency, resolution or fall in the New York Heart Association. And the fall in the gradient favors septal myomectomy rather than ASA. But I still feel that it depends on your center, which center does things better. If you've got lots of experience with surgery, then of course it should be surgery. Otherwise, if you've got more experience with alcohol, then it should be alcohol. I hope to be taking about 5 more minutes, JKK, because we started a bit late. Now, let me share to you what we do, because this is something that we do a bit more routinely when I was in IGN, but I nowadays tend to do it about 3 or 4 patients in a year. So this is an angiogram, and we identify the septal branch, which is the first septal branch, the highest, and in this case is a large septal branch. This is done under sedation. So we put in a balloon. This is an over-the-wire balloon. We inflate the balloon. And in this case, we inject it antegrately to make sure that it obstructs the artery, because otherwise we don't want the alcohol to spill back into the LED and cause infarction. We also check that when injecting through the balloon to see that doesn't leak out into the artery. Plus, at the same time, you can see an echo probe here. We then identify from the echo, because I don't do contrast echo. By injecting contrast, you can actually see the filling up the septal branch, septum, and then you know whether you're actually at the site, because you are aiming for the basal septum. And this is what we did. So this is before, and this is after injecting contrast. You can see that it brightens up at that particular area. So I know that that is the area that I am aiming to do. So since I identified that that is a proper artery, so we injected alcohol, and you can see the alcohol as it's been injected, slowly you find that it brightens up a bit more. And you also find that there'll be hypokinesia of the septum. Okay. So this is what it looks like from the 4-chamber view. So how do we do this? We assess results by looking at the pressure gradient across the LVOT. We look at the hypokinesia of the basal septum. We look at the rhythm and QRS morphology, because they can go into complete AV block. And as I always remind people, that they don't go into 1st degree, 2nd degree, and then complete AV block. No, sometimes they can just send sinus rhythm and all of a sudden go into pauses, ventricular standstill. So you need a temporary pacemaker for when you do this procedure. At the same time, we look at the hemodynamic pressure gradient across the aortic valve. So those are some of the things we look at. The patient changed to broad QRS complex, went to 3rd degree AV block for a few seconds, and then went back to sinus rhythm. So that's an indication, do not proceed further. That'll be enough. And this is typically what we find in post-TASH. You can see that there's like competitive flow in the septal branch that you ablated before, and that suggests adequate, one of the things to suggest adequate ablation. He had an ECG. This was an ECG right bundle branch block, but still sinus rhythm, and he remained in this ECG. Just to show you why it happens, because when we give through the septal branch, it goes very deep. This is where the right bundle branch block is, so you can get right bundle branch block. Whereas a surgeon goes in a bit more superficial, from the septal side, so that can affect the left bundle. So if I were to see a person with left bundle branch block, I will not do septal ablation, because when you do it, there's a chance a patient will go into complete AV block. All right, so he was nursed in HDU for 1 day and discharged, remained in sinus rhythm, pacemaker taken out the following day. That's cardiac biomarkers. The higher it is, of course, the more infarct that you cause. And he came back, this is post-TASH. So you can see what it does is that there is hypokinesia in the basal septum. And the peak gradient dropped to 57. This is the following day. And that was a gradient. So he was discharged with a gradient 57 from 150. He came back again a couple of months later. He felt much better. The gradient, there's still a murmur. There is still mild to moderate MR, but when he came back about 9 months subsequently, there was no dyspnea. He did very well on the treadmill, 15 minutes. There was no murmurs. And this is what you see, the pre-TASH, post-TASH, and then the 9 months, you can see that the basal septum is now is much less It's not even hypertrophied, and there's no SAM, there's no obstruction. Very trivial MR. And then the gradient has come back down to 25 mmHg. So no SAM. So that's with septal ablation. Briefly, KK mentioned about the mavacamten in the Explorer HOCM study. One of the proteins acts on the proteins of the heart that drive contraction. Briefly, just to show you the results. And this is only for 30 weeks. And you can see that the primary endpoint in terms of symptoms and functional reduction was much better by half reduction, 50% reduction. And then there's what is interesting, the exercise LVOT gradient was much lower. Reduction is much more than placebo, and even the function class is much better. And the questionnaire symptom quality of life. And the questionnaire. Sorry? All right, okay. So just to conclude briefly, this is a patient that I presented with HOCM. Remember that 70% presents with LVOT obstruction, and they have got an increased risk or poorer survival. And treatment is mainly aimed at elevating symptoms and sudden cardiac death, as mentioned. The first line is really medical therapy, but septal reduction procedures may be considered if still symptomatic. And remember always, to reduce sudden cardiac death, it is by ICD. I briefly touch about and show you how an alcohol septal ablation is to be done, and a novel drug that may show promise, but it is early in the day with only 30 weeks, and we need to see it over a long period of time. So thank you very much. Last, sorry, KK, I took 2 minutes of your time. Is there anything that you like to add to this case?
What were the symptoms after 9 months on the follow-up?
Yeah, there is no symptoms. He went on treadmill and he did 15 minutes of exercise. And obviously, as I mentioned, there is no MR clinically, and it's trivial on echo. So much better symptoms. And as we tend to see over time, you tend to see the LV over time becomes less and less. The reduction in MR will also not be immediate. It will be a couple of months' time, and you find that the MR actually disappears most of the not. If it's due to HOCM, not a primary MR problem, not a primary mitral valve problem.
Thank you.
Yes. All right, KK, sorry. Shall we move over to your side? Thank you very much.
Yes.
That was fun.
Thanks, Rosli. That's a very nice case, and I think you illustrated the various key findings of HOCM very well. With the change in the SAM and the outflow tract gradient. So very, very nice. Okay, so this session is meant to be interactive. So let me show a case here. This is or rather a few series of cases. We'll see how it goes. And can you all see my screen? Yes.
Not yet.
Is it? Can you all see now?
Yes.
Okay, great. So it's great to see all of you on Zoom. I much prefer to be in Cambodia and see all of you in person, but I think hopefully next year we can do that. So I'm going to show mitral clip cases, and maybe let's start off with one for tricuspid regurgitation, which of course is not commonly done, but I think we are seeing more and more of it now. So first, I think we know that TR can occur for both primary etiologies as well as from functional. And the causes of primary TR are multiple. They are not common, fortunately. For functional TR, it's much more common, and this can occur from left-sided disease or disease related to the lung, including pulmonary hypertension. But for functional TR, it essentially occurs when the TR is in the presence of structurally normal leaflets and not due to structural abnormalities of the tricuspid valve. And this is largely due to deformation of the tricuspid valve apparatus, which would include annular dilatation and leaflet tethering. And this oftentimes is due to right ventricular remodeling. So just some pictures to show that. You can see that in functional TR, the septal leaflet is often fixed, and the tricuspid annulus can dilate, typically in the anterior posterior aspects. And of course, with that, the annulus becomes circular. The tricuspid annular area increases with flattening, and this further worsens any prior tricuspid valve leaflet coaptation. Now, I mean, before I talk about the tricuspid clip strategy, maybe just to ask Kenny. I mean, I know that typically surgeons don't like to operate on isolated tricuspid regurgitation. Can you share a little bit as to why that might be the case?
Yeah, I think, for the tricuspid valve, we rarely get a primary tricuspid valve pathology. Most of the tricuspid valves that are referred are secondary to left-sided lesions. So when there are secondary tricuspid regurgitation, we would operate when we are correcting a left-sided lesion at the same time. An isolated tricuspid regurgitation, especially in the presence of severe pulmonary hypertension, I would say most surgeons will not do it because your surgical risk is very high. And the primary concern is that these patients go into RV failure, which is a very difficult problem to solve. So ideally, with TR, we would want to solve it at the primary operation and not have to, and frequently what happens is that at the primary operation is not addressed or it recurs, and then they come back, and then you're talking about a redo on a functional tricuspid regurgitation. So most of us would be fairly reluctant.
Yeah, so that's our I mean, one reason why I think there's a space for using the clip as a strategy. Now, I must say that our experience is very early, so I still continue to learn as to what the kind of patients we should select for using the clip. And we have other therapies coming our way, but for now, I think the mitral clip, or hopefully in time to come, the tri-clip will be an option. These are some pictures to show you what we hope to do. Most times, the TR in a tri-leaflet valve is somewhat the how do you call it, the regurgitant orifice is somewhat stellate, and we can put the clip in a few spots. The typical area that we will put a clip on is between the anterior leaflet and the septal leaflet, and sometimes we would put it between the posterior and the septal leaflet. I've yet to see, I'm sure it has been done, but I've yet to see, and I've not done a posterior to anterior leaflet before. And you can see in the picture here, this is what the clip might look like. You end up with a tri-orifice valve, and typically this does not make the TR totally go away. Typically, there's still significant tricuspid regurgitation, and but in the clinical experience that we have seen, both in our both locally in Singapore as well as globally, it appears that just one grade reduction will result in significant clinical improvement. And this is just some a slide to show what some of these severity improvement grades would be. So typically in the traditional grading system, it is just 0, mild, moderate, severe, moderate to severe, and then severe, just 4 grades. But in 2017, Rebecca Han and Jose Zamorano had proposed a different grading system. And that is because, for TR, you have severe and then you have really, really severe. And people were having difficulty trying to figure out how to differentiate the various categories of severe. In our experience, most times if you hit massive or you have to hit massive or torrential before it really becomes bad. And this is just some illustrations as to what that might be, on the bottom of the screen, illustrative images showing what severe, massive, and torrential will look like. Of course, we have to measure the vena contractor as well. Now, when we select patients for mitral clip, for the tricuspid valve, there are many, many criteria as to what is ideal, what is maybe considered, and what we really don't want to do. I think the key area which I want to highlight is where there is insufficient echocardiographic windows for leaflet visualization. When it is red, as in traffic light red, we try not to go there. And of course, conditions such as where there's a large coaptation defect can still be considered, because we, as I mentioned, we don't have to reduce the TR by a lot, and if we can clip from the edges, sometimes we can improve on that. But even then, if it's more than if there is a coaptation defect of more than 7 millimeters, we try to avoid it. The presence of a pacemaker lead is something that we are mindful of, but it does not prevent us from doing so, especially if the TR is not from the pacemaker lead. And if there's time, I can show a case that's on that as well. And of course, in the setting of severe pulmonary hypertension, we are also a bit reluctant, because the underlying driving force for the TR is from the pulmonary hypertension, and the pulmonary hypertension itself can cause symptoms, obviously, and we may not be able to help the patient. So the in-betweens, the challenging cases, I think is somewhere in between, and we can consider that. So let me just illustrate with a case, and please jump in and ask questions or give comments along the way. So this is a 68-year-old lady, and this is our first case in Singapore. History of primary biliary cirrhosis with a liver transplant, chronic kidney disease, atrial fibrillation, had been in 2 different institutions before transferring over, over staying more than 3 months, repeated intensive care unit admissions, heart failure requiring intubation, mechanical ventilation, pneumonia, fortunately not COVID, at this time there was no COVID yet. Renal, the CKD stage 3 progressed to dialysis and was on, a bunch of inotropes. And this is her echo, which I will just show, and I should mention that her coronary angiogram was normal, and she has both severe functional MR and severe, in this case, massive functional TR. There is a coaptation gap, and the EF was diminished, I think, as a result of all these abnormalities. So I'm going to show the echo here. You can, I think, first of all, appreciate the MR, and this is obviously severe with a very restricted posterior leaflet. The underlying cause of her MR and TR is not quite clear. I think it's probably from her underlying kidney disease, and I'm not quite sure what else, what we couldn't, of course, find out what was the cause of the MR to begin with. And then this is the TR, and this is massive. I think, the TR jet swirls around and virtually covers the entire plane of the annulus as seen on this picture. So I guess the question maybe to ask is, what else should we do? I mean, would you even offer a clip for this patient? Would you offer surgery? And maybe I'll ask Sok Chour, I mean, any comments? She's a liver transplant patient, dialysis, inotropes, 3 months in hospital now. Sok Chour or Alex, maybe?
We don't have much experience with the right-sided, but that can be discussed with the heart team, the surgeon, the interventional, regarding the options that can be done for this patient. And I think the doing something for the right side will help the hemodynamics of the patient.
Thank you. Kenny, what about you? I mean, I don't know whether you remember this patient, but yeah, it was a tough one to go through.
I don't specifically recall, but I would assume that by this time she's already been medically optimized, all the heart failure drugs, diuretics, and I think if you are reached a stage where medical therapy has reached a dead end, then intervention one option. And I'm sure, if we have encountered this, we must have then discussed really what's the best way of going in, surgically. She's functional MR, functional TR to go in and fix both valves, you are looking at probably a mitral valve replacement and a tricuspid valve procedure. Annular size of 35, is not that dilated. And with all the comorbidities, she would definitely be a very high risk candidate, especially she's been in the hospital for quite a while. Yeah, so I guess, at the end, the discussion must have veered towards lesser risk percutaneous procedure. Yeah, but the question here is then you have to tackle both the valves.
Yeah. So this was a difficult case. In fact, I rejected her at the beginning because we have never done a tricuspid clip before, and I felt that the last thing I want to do is to do it on the liver transplant patient in ICU and inotropes. But the ICU director of the ICU in a medical intensive care called me and said that, hey, look, they think this patient can make it, and they wanted me to give it a try. So the heart team had a discussion. She's got all these, horrible comorbidities. Euro score is high, STS score is high. She's frail and she's really on inotropes. But after the intensive care, director called me, we say, okay, let's do it. So this is the first part of the procedure. We put in a clip to the mitral valve. The result is not perfect, but there we were having an unstable patient, and I did not want to spend too much time, adjusting because it's just first part. We reduced the MR to moderate. I think the reason why it's not perfect is because the perpendicularity is not perfect, but I think it is adequate. The MR was reduced, and we then proceeded to do the tricuspid valve intervention. And in this case, we had to make some adjustments to the steerable guide. First, we put it back into the right atrium, and then we had to put in the mitral clip delivery system. Now, bear in mind, this is meant for the mitral valve, and based on what others have done, out of Europe and the United States, we knew that we had to miskey the clip delivery system and adjust and steer the device towards the tricuspid valve as shown as what I've written on the screen, which is to use the A knob in the miskeyed system. And here we were really lucky. I don't know whether you all can see well the septal and anterior leaflets here, and we were able to somehow or another just basically catch hold of the both leaflets. And this was before we had a XT system. And you can see on the screen here the grasping of both leaflets. I hope it is clear, but you can see that we were able to grab the leaflets. I'm going to let it run one more time. Bring the septal here, the septal leaflet and the anterior leaflets together, like so. And and this is showing that the leaflets were well grasped and stable with restriction of both the septal and the anterior leaflets. And I think you can also appreciate in the in what we would say would be a sort of a somewhat intercommissural view, short axis view, where we can see that the septal and anterior leaflets are restricted now, and only the other orifice is open. So this was was, I must say, really fortunate. And you can see that with the clip on, there is still TR for sure, but because we know that you don't have to make the TR totally go away, we were quite happy that the TR was reduced to moderate. The valve area, when we using 3D, is still substantial. It was reduced to about 1 cm square from almost 2. And this is, on a transthoracic, subsequently, you can see there's still TR, but much better compared to before. And I think you can see the 2 clips on this frozen frame here. And when we released the clip, both clips were stable. So the patient was extubated the next day. Weaned off inotropic support, was discharged, rehabilitated, and never had to be readmitted for heart failure for more than a year. She eventually passed on from other reasons, but this was our first case. We published it and we were quite happy. I know that there isn't much time, but maybe just to pause and ask if there's any questions from anyone, comments. Rosli?
It appears that because I don't do mitral clips, but the tricuspid valve, it's much more larger, and the valves tend to be a bit more redundant. So I presume technically it's going to be more difficult, correct?
Yes. The using a mitral clip for the tricuspid valve is a lot more difficult, partly because the equipment is not meant for the tricuspid valve. So all the distances, lengths, and steering is all all in the wrong place. Kind of like trying to play tennis with a table tennis bat. Everything is off. The second thing is that the imaging is really challenging. We were very fortunate that our imaging echocardiologists were really really wonderful, and they got us very nice images. As you saw, without those images, we don't know what we are grasping. So this in this case, those are the three big challenges with using the clip for the tricuspid valve. At that time,
sorry.
No, I said at that time we didn't have the XT system, which has longer arms. We only had the NT system, so that was also a technical limitation. So I think those are some of the considerations at that time. Oh, sorry, Rosli, you were going to say something?
Yeah, I think we are also waiting for our first case, but we are hoping to use a trick valve device, which I presume in this case maybe perhaps it might be good because it's much easier to be deployed if the indications are appropriate for the device. What do you think?
Yeah. So the trick valve, we are going to start. We already have some patients lined up and they have gone through screening. So waiting for the first case. I think that might indeed be a good case. I think the problem with the trick valve, however, is sizing and working through the fact that this patient has liver transplant. So I'm not sure how the anatomy would fit. The second thing is that the MR is also substantial, so the trick valve wouldn't fit. Wouldn't fix the MR. So I think now as we get more devices in our armamentarium, it would definitely be a consideration for us.
So KK, this was for your first case. So how are your subsequent cases now with the
we have done about 15 cases. I think in one case we although we could grasp the leaflets, we could not reduce the TR, and that was in a patient where the gap was more than 1 cm. That patient will go for the trick valve soon. In fact, that's probably our first patient. And then in another patient, the valve tore. There were 2 clips put, but there was a tearing of the valve, and that was in the atrial functional TR case. And that was patient went for successful surgery. I think there was another case where we just couldn't get a good result. But I would say that maybe about 80% we have a good result and we help the patients. But I must say that it's early in our experience, and hopefully with the tri-clip system we get a better result, because sometimes the steering is a nightmare because the knobs are all wrong way, upside down, and we are not sure whether the knobs go the right way. But typically we follow the instructions and the rules and the guidance, and we can get there, but it is an uncomfortable procedure. And we reserve it only for patients who are very symptomatic, and we make sure that they are informed that this is off-label and limited experience in our institution. The good news is that because we're operating on the right heart, the risk in terms of the risk of stroke, etc., is lower. So I also make a point to tell the patients that, look, if I can't get a good grasp, I'm just going to stop. And indeed, we had one such patient where there were other considerations, and with just one grasp, we had enough TR reduction. We just stopped then and there. Or that patient had had GI bleed from some vascular malformation in the soft palate and started bleeding. So we put in one clip, and the patient had good TR reduction. We would have wanted to put another one, but the bleeding stopped us, and the patient eventually did fine. So I'm mindful of time, and maybe I'm just going to stop the presentation here, and instead maybe just we can discuss some of the considerations for the use of the mitral clip in the tricuspid valve, by saying that overall this is very early in our experience in I think in this part of the world, and the therapy is expensive, but I think it does offer patients who don't have much of an option some options. And as Rosli mentioned, there are new therapies coming, tric valve, the actual tri-clip itself, and then hopefully with time things like the Pascal or the Cardioband, I think may offer other treatment options. So I'm just going to pause here and ask Rosli, what do you think? Would you like to add on to that?
Rosli, you're muted.
Unmute, Rosli.
Thanks. I think the number of cases for so-called functional TR is not as great because most times or not the surgeons would have repaired it. But when we see it, it's going to be quite difficult to treat because there's always a reluctance of the surgeon to go in just to treat the mitral, the tricuspid valve itself. So if we have a mechanism that, or rather device that can treat this, it'll be much better. And by the time they come to see us, that they have got liver impairment, there's edemitas, and that poses a problem. The albumin is low, and so on and so forth. So at least the way I see it, that the surgeons are not really keen in just treating, especially when patients are ill. I hope I'm right there, Kenny.
Oh, yes. That's why I mentioned earlier, we are a bit reluctant to go in for isolated functional TR.
So Kenny, you'd be very happy to pass on the patient to the interventional cardiologist.
Yeah. There's
poor surgical risk.
There is a question, yeah.
Is there a cutoff value for RV function TAPSE when considering tricuspid clip?
We would say that as long as it's
do you think the mitral clip is working for the tricuspid valve in patient with Epstein disease or not?
Epstein's disease, no, we have not. I think that one is tricky because the anatomy is even worse off. But I've seen others do it before. There's been case reports, but I'm not sure whether I would try it. To be honest, I might, as Rosli said, use something else like a tric valve. As to whether the RV function is an issue with regards to TAPSE, I would say that as long as there's not worse, unless it's severe RV dysfunction, if there's moderate RV dysfunction, I would be okay with it. I'm not sure whether there's a number that's been shown, in the literature specifically to answer that question. But I would say unless it's severe RV dysfunction, I would still be okay. Because if you fix the TR, and because we can't make the TR totally go away, usually there's a bit of some regurgitation left that will help with the loading conditions. Yep, over. So I think we are at 2 p.m. I don't know, Rosli, do you want to help close the session?
Sorry, I think you go ahead, KK. Why don't you close the session? To me, it's been very interesting, exciting. I've learned a bit, and and I just enjoy the interaction that I've been missing so long. And that to me is something, to see Sok Chour, to see Alex, and to see Kenny, that's I'm happy enough.
I enjoyed the session with you guys too. I missed you all.
Thank you. So thanks very much. As Rosli and Alex mentioned, I think one of the best part of the ASEAN Federation of Cardiology Congress is to meet all of you in person. We can't meet in person, but we are doing the next best thing, which is on Zoom. And I think there's been a lively discussion on some of complex cases that would be somewhat uncommon, but nonetheless illustrates key learning points in cardiology. And we've heard from Rosli on an incredible HOCM case with a lot of learning value, a lot of steps, and great clinical improvement. And then, we also discussed the use of the mitral clip, in this case for tricuspid regurgitation and mitral regurgitation, bringing a promise of things to come for all of us in this region. So with that, I'd like to close the session. Thank you everyone again for spending your Sunday with us, and I hope to see you in person next year. Thank you very much. Have a good day.
Thank you.
Thank you.
Thank you.